Hi everybody, this lecture is going to cover treatment for hypertension, and I have a lot that correlates with chapter 47 in here. Some of the tables are different that I have within here, but I will post this PowerPoint lecture for you to review as well. If you have not done so already, make sure that you go through the chapters that cover each individual antihypertensive or cardiac medication, just so you have a good understanding of them before you move through this lecture. In terms of classification of blood pressure, our goals of treatment and in the ideal blood pressure readings are essentially developed by guidelines. And this is JNC7. There is a new one that came out in 2014. So a lot of these are very similar. They just added some more information to the newer one. And I will kind of go through this with another table that I have posted within here. So we'll kind of review that as we go through. But as you can see, obviously, there's normal, prehypertensive, and then hypertensive. And it's essentially divided out into different categories and where our target is and where the patient's blood pressure lies. It would put them within a category. And this is kind of essentially how we guide our treatment. In terms of hypertension, there are two broad classifications of hypertension. We have primary or essential hypertension, and then we also have secondary hypertension. Primary is essentially there's no identified cause. It's just essentially they have hypertension. Sometimes it could be genetic, and obviously there's lifestyle factors that play a role in this. And then different populations may have more prominent issues with hypertension, such as African Americans, postmenopausal women, and then just as the individual ages. Hypertension or essential hypertension can be treated, but it cannot be cured. So it's usually a lifelong condition that we have to manage. And this is referred to as essential hypertension. Now, secondary hypertension is usually related to an identified cause. This may be kidney disease, or the patient may have hyperthyroidism, Cushing's syndrome, which is an endocrine disorder. Certain medications can induce hypertension, for instance, like ADHD medications, or even any agent that would, bump up the CNS or activate the central nervous system. For instance, like Sudafed, that's over the counter for nasal decongestant. Long-term use of these medications may predispose the patient to developing hypertension. NSAIDs are also another medication that I wouldn't say it causes secondary hypertension, but it definitely will increase the blood pressure because it has a high salt content. So they retain fluid, obviously, and then their blood pressures kind of rise. So the secondary hypertension, obviously, there's treatment available to essentially cure the hypertension. I put this table up because this is a list of different medications that can cause a rise in blood pressure. And as I mentioned, anything that stimulates the sympathetic nervous system, which, like I mentioned, Sudafed, amphetamines, NSAIDs, like I already mentioned. COX-2 inhibitors are an anti-inflammatory as well. Those are like Celebrex. We'll cover those later down the road. Steroids can too. A lot of this is related to sodium and fluid retention. A lot of them are very dose related, so the higher amount of steroids the patient's on, the higher their blood pressure readings can go up. CNS stimulants, caffeine is one of them too. So these are important things to always talk about with your patient as well. With lifestyle modifications such as caffeine intake, tobacco smoke, and then over-the-counter agents that they may be taking as well. Estrogens and progesterones, like I mentioned, HRT, and oral contraceptives. The other factor too with this, when we'll discuss women's health, they also have effects on clotting. So that's another factor kind of outside of this, but that's something to think about too. Certain dietary supplements can cause a rise in blood pressure. NRIs, which we kind of talked about last week with venlafaxine. And then certain immunosuppressants can cause that as well. In terms of pharmacologic therapy, it's really important to kind of look back at how the cardiac system works, essentially, and how our blood pressure is controlled. Because obviously a lot of these agents are working through targeting our normal physiologic process. So the principal determinants of blood pressure essentially is your cardiac output, which consists of all these areas, and then your peripheral resistance, or the resistance that it's pumping against. And that's where you're going to get your arterial pressure, essentially. So anything that can affect your cardiac output or peripheral resistance is going to obviously increase or decrease your arterial pressure. Cardiac output is determined essentially by your heart rate, contractility, your blood volume, and venous return. So it's all those factors combined. So if you change any one of these, it's going to have an effect on your arterial pressure. So a lot of these agents essentially are working on various parts of this to help reduce the blood pressure. Other systems that help regulate blood pressure as well. One thing too, it's just important to kind of understand, because I think it'll give you a better understanding of like reflex tachycardia and orthostatic hypotension, is the baroreceptor reflex. This is through your sympathetic nervous system. You have baroreceptors essentially in your in numerous spots, but mainly like you'll notice them in your in the carotids, and then they're in the aortic arch. But these are essentially are like sensors. They censor what your blood pressure would be at that point in time, and it senses if there's a drop in blood pressure or a rise in blood pressure. And it actually, this is, like I said, it's through the nervous system, so it's stimulating back up to the brain. So it's that sympathetic nervous system response that is controlling our blood pressure. So for a patient that has orthostatic hypotension, when they go to stand, your baroreceptor response will kick in essentially and try to combat those effects and normalize your blood pressure. That's just the reason why I brought that up, so you have a little understanding of why these side effects happen. Same thing with reflex tachycardia. You're giving agents essentially to reduce the blood pressure. Sometimes when you're reducing the blood pressure, your baroreceptors will kick in essentially and try to bump up your heart rate in order to basically fix something that it thinks is there, if that makes sense. They have essentially stretch receptors, and the increased pressure or decreased pressure will sense the stretch in the blood vessel where they're at, and this is what initiates that sympathetic nerve response. So essentially all it's doing is informing the brain about increases and decreases in blood pressure, but that's how you get some of these side effects and how our body essentially compensates for it. Another system, these two, which your renin-angiotensin-aldosterone system, and then renal regulation of blood pressure, these kind of interact together. Your kidneys have a huge impact on your blood pressure, obviously, and the renin-angiotensin-aldosterone system also has that too. And a lot of this is through direct vasoconstriction of arteries and affects through the kidneys, essentially. So obviously you can have differences in your blood volume, and a lot of that is regulated by your kidneys. Now, going back to the JNC guidelines, this I put up. I don't expect you to be able to know how you would treat exactly a patient with hypertension and what stage they would be, but I feel like it's a good way to understand why these drugs are indicated, which ones are used when. It just kind of lays it out a little better for you. Two important things, patients with diabetes and patients with chronic kidney disease. A lot of our treatment and medication choices are dependent upon comorbid factors. So if a patient has underlying diabetes or kidney disease, or even if they had significant cardiovascular disease, a lot of that determines the agents that we choose for the patient. Typically, in the average person who is pretty healthy and just has hypertension that develops, usually our first-line treatment is a thiazide-type diuretic. That's our first gold standard go-to agent. That's if, like I said, if they have they don't have other underlying issues. And kind of depending on the stage that they're in, if they're real high, then sometimes we may consider another agent like an ACE or an ARB or a beta blocker, or even in combination. There's a good chart in your text, and it's on page 506, and there's combination products. I don't expect you to memorize all that, but as you can see when you look at that page, there's many of the agents that we give are available in combination formulation. So a lot of them will be an ACE inhibitor combined with a thiazide diuretic, or an ARB with a thiazide diuretic. And then we even have other medications that would be like a calcium channel blocker plus an ACE inhibitor. So a lot of this is, for ease of administration, obviously, for the patient, and it can help with that adherence as well. So as we move up to higher stages of hypertension, a lot of times we'll go with a 2-drug combination, and I'll kind of go through this one on another page too as to why we pick what we pick. The compelling indications is the portion that I mentioned about underlying disease state. So That has a huge impact on what we choose. The biggest thing, too, with these patients is lifestyle modifications. Even if we are putting on medications, they do have to institute lifestyle modifications, which I'll discuss in a moment. Now, this chart I put up because I just feel like it's a good way to go through these meds with you and give you the essential information in regards to side effects or what you would be looking for, just to kind of give you some information about these. In your book, too, on page 504 and 505, on 505, there's actually a table of antihypertensive with effects and certain, drug actions with it. That table is a good kind of table to kind of look at for where these agents are kind of working at, too. So that's a good table to kind of look at as well. So let's take a look up here real quick. Thiazide diuretics, as I mentioned, these are usually our first line agents that we use. As I mentioned, it's usually the drug of choice for uncomplicated hypertension, and it works really, really well with other agents. So you'll see it used in combination a lot. Things that you do have to look out for, and these are like the side effects or issues that you have to be kind of aware of. Gout, it can potentiate hyperuricemia. So gout is from having high levels of uric acid. So if someone has gout, thiazide diuretics can actually potentially make that worse. Hypokalemia, because remember this is a diuretic, they could be losing potassium with that. And as I mentioned in the diuretic lecture, when you're looking at a lot of these agents, think about that too in the back of your mind. Which one increases potassium? Which one decreases potassium? What would happen if you put them together? Is it a good idea to put them together? You have to kind of think about that in the back of your mind with potassium levels. Because as I mentioned, thiazide diuretics can decrease potassium. However, like when you look at ACE inhibitors can actually increase potassium. So actually combining an ACE inhibitor and a thiazide diuretic would probably balance them out. Those are just kind of the factors that I mentioned to kind of take a look at. ACE inhibitors, you'll see time and time again, ACE inhibitors, a lot of patients are on these. They're really good drugs. They're great for hypertension. They're great for CHF. And they're also good for patients that have diabetes and they have nephropathy because it does help protect the kidneys if they have hypertension and diabetic neuropathy or nephropathy. Contraindications to an ACE inhibitor, bilateral renal artery stenosis. So as I mentioned, it's good for nephropathy, but that's usually related to hypertension or diabetes. Now, if there's stenosis, that's different because the stenosis is actually narrowing of that artery. So an ACE inhibitor is trying to work at the kidney, but that stenosis would be a contraindication. In terms of monitoring, BMP means basic metabolic panel. So that's just like your electrolytes, your liver, your kidneys, essentially, just looking at blood work. Going back to the diuretics, one thing to know with diuretics, it loses effectiveness with a decrease in GFR. So if their kidneys are not functioning properly, a thiazide diuretic is not going to be very beneficial for the patient. And this drug can induce basically like a lupus type syndrome, essentially. It's pretty rare though. As I mentioned with ACE inhibitors, you have to look for hyperkalemia because it can hold on to potassium when you're on these medications. One of the biggest ones, and I know in Dr. Meisson's lecture she mentions it as well, is the cough. This could be pretty problematic in patients, and it's because of the increase in bradykinin. So a patient that develops this chronic, it's usually a dry cough. Sometimes they can't tolerate it and they have to be switched. A lot of times if you switch them to an ARB, they'll do fine, which is the angiotensin receptor blocker. Because these two, ACE inhibitors and angiotensin blockers, are very similar in actions. ACE inhibitors tend to be the go-to, but this would be like your second backup. They do not have the side effect of having a cough with angiotensin receptor blockers because it doesn't have a significant effect on bradykinin. With both of these, angioedema, which is essentially swelling of the lips, it can have swelling in other areas, but a lot of times you'll see it prominently or predominantly within with their lips. So obviously that would be a contraindication to continuing the medication. Both of these can cause hyperkalemia as well. Beta blockers, you'll see these used a lot. Beta blockers are used a ton in any patient that has any cardiac history. If a patient has had a previous MI or if they've had stent placement or open heart surgery, all those patients should be on a beta blocker. And it's not even necessarily for blood pressure treatment. It's basically to um, decrease that workload on the heart. So there's other factors. It's almost like a heart protective mechanism that we do with beta blockers. So it's not even necessarily just for blood pressure. It's used for other reasons as well. As it reads here, patients with coronary artery disease, long-term management of CHF, hyperthyroidism, because with hyperthyroidism you can see hypertension as well, or you can see tachycardia. So beta blockers would decrease the heart rate and decrease the blood pressure. Beta blockers on their own for hypertensive therapy are not they're effective, but they're not as effective as other agents. So that's why I say beta blockers have kind of a unique place in the treatment of hypertension. If the patient has a history of an AV block, this is kind of like a rate control medicine. It's controlling their heart rate essentially. They won't have these bouts where their heart is up in the 80s. A lot of times these people that will be on beta blockers, their heart rate will be in the 50s. The resting heart rate will be like 50 or 60. And that's not uncommon to see with a beta blocker. And then now thinking back to when we talked about the nervous system, think back to alpha 1, beta 2. Remember that we're targeting beta 1 with beta blockers, but you can get some of that hit on beta 2. So that's why these side effects like a bronchospasm could be there too as well. Now, calcium channel blockers, when you take a look at these, they're kind of divided out into two different types of calcium blockers. There's verapamil and diltiazem, and then we also have the second dihydropyridines, which are a little different. That are essentially nifedipine and you'll see Norvasc, which is amlodipine. Those are the dihydropyridines. So those have more direct effect on the vessels, where diltiazem and verapamil have both effects on the arteries, in the peripheral cardiovascular system, as well as on the heart directly. So when you get into heart failure and all that too, we'll kind of cover that a little bit with that, but so a lot of times for blood pressure control, you will see agents like amlodipine, which is Norvasc, or you'll see nifedipine used for hypertension. Diltiazem and verapamil are kind of, they're used in specific cases with certain types of patients, essentially. And remember, too, when Dr. Meissen talked about calcium channel blockers, think back, too, about beta blockers and agents like diltiazem and verapamil. They both are going to decrease the heart rate of the patient. So you're never going to combine, diltiazem or verapamil with a beta blocker, because we would have that same ultimate effect on the heart. So like I said, for hypertension, you'll mainly see agents like Norvasc, which is amlodipine, or nifedipine. One other thing that I wanted to point out too is calcium channel blockers tend to be more successful essentially in African Americans. Sometimes beta blockers are not that effective with African Americans, so calcium channel blockers are known to be more effective with African Americans as well. So in a patient that they're having a hard time managing their blood pressure, sometimes it's a good agent to go to. One complaint with especially Norvasc, you'll see Norvasc, amlodipine used a lot. Nifedipine you will see, which I know that's the prototype in your textbook. Personally, I run across Norvasc more than any of them. One of the biggest complaints usually with it is edema. Sometimes I'll have lower extremity swelling in the legs. And it's really not detrimental to the patient. It's just kind of one of those side effects that is essentially kind of an annoyance to the patient. And then even this here says some affect heart rate. Those are more like the agents like diltiazem and verapamil. So when you look at calcium channel blockers, you got to kind of think about them as two separate categories within the one category. Now, these last two agents down here are not used as significantly. An alpha-2 agonist like clonidine, this is actually working through your nervous system. So it's used here and there, and hydralazine is used here and there as well. Hydralazine can be used in pregnancy, so that's one indication for it. It can be used in the pediatric population, and it can be used sometimes in conjunction with other medications for like a hypertensive crisis, which I'll talk about at the end. It is contraindicated in coronary artery disease, so a lot of these patients, it excludes them from using this right away because of coronary artery disease. It can cause that lupus type drug reaction as well. So these are two other agents to kind of think back in your mind, but really from here on up, these are the ones that you will be seeing used for hypertension. And then in your book, I know I was just talking about calcium channel blockers, but on page 489, there's like a comparison and contrast chart with diltiazem, I think, and nifedipine. I think those are the two that they compare. But it gives you a good idea, like I mentioned, about kind of separating them out into the two separate classes within that one. Now, this is, I don't expect you to memorize all this. And this is just to give you an idea of when I went through that one chart, this chart, compelling indications. This is kind of where this comes in. So when you're looking at patients that have a history of coronary artery disease, like I mentioned, all those patients should be on a beta blocker. You know, if they had any heart history or stent placement or angina, we always use, a lot of times we use ACEs in combination with a beta blocker too. Recent MI, same type of thing. We always have them on a beta blocker. Hypertrophy, an ACE inhibitor, these patients are prone, if they have left ventricular hypertrophy, these patients would be prone to heart failure. So we would have them usually on a diuretic or an ACE and an ARB with that. And then diabetes, that's another comorbid condition that we always typically try to put the patient on an ACE inhibitor with us as well. Same thing, chronic kidney disease, we try to have them on an ACE inhibitor. I'm just trying to get that, across to you that why we use certain agents for certain reasons. So now some principles for antihypertensive agents. So as I mentioned, therapeutic goals are established for the indication or the comorbid conditions that the patient has. So treatment decisions are obviously always individualized and based on the goals what we have for the patient. Our preferred agents are usually determined by whether they have chronic kidney disease or underlying cardiovascular disease. In terms of dose escalation, typically you're going to put them on an agent and sometimes it'll be combined agent. And we do try titrating them up a little bit. Usually you start them on the lowest dose, you'll titrate it up a tiny bit. I tend not to max their dose out on one agent. I usually would put them on a medium level in the middle dosing and then kind of see where they run with that. You can put them at the higher dose. But sometimes at that point, if they're only on one agent, sometimes we'll put another agent. Like for instance, if they're on a diuretic, I would add them on an ACE inhibitor versus maxing them out on a diuretic. So it just kind of depends on the patient really and their underlying medical history as well. But in terms of evaluation, you always are going to ask about adherence. Are they taking the medication every day? You'll run into this, unfortunately. Patients think that it's an as-needed medication, when it's truly, obviously, it's not. It's something they have to take every day to manage their blood pressure. So just basic education about that as well. Another thing, too, to discuss with your patients, if they're on multiple medications, sometimes it's better to dose one in the morning versus one at night. Obviously, with diuretics, I always tell them to take them in the morning because, you don't want them getting up and going to the bathroom all night. But some of these medications, if you look at the half-life of them, they don't get the greatest 24-hour coverage with it. So sometimes a patient could have hypertensive issues at night and really not know it, unfortunately. So sometimes if they're on multiple medications, we'll dose them spread out a little bit to get better coverage of that blood pressure. Another thing I meant to mention too, when I was discussing secondary causes of hypertension, now that we're on the topic of sleeping and all that, sleep apnea is a huge factor that contributes to hypertension. A lot of patients don't even realize they have sleep apnea, but it definitely predisposes that patient to having or developing hypertension. So that's something to always inquire about with your patients as well. Are they waking up gasping for air? Do they have any difficulties with sleep, or are they fatigued during the day? That's a little side note that I wanted to mention earlier in the lecture. Back to this. So essentially, as I mentioned, a combination usually will get better efficacy if you have a combination of agents here, because you're working on different systems. Some may be working on the sympathetic nervous system, some may be working within the kidneys. It's just kind of looking at what agents to use together. Some may actually reduce the side effects of another agent, like I mentioned when you're looking at potassium. If a patient's on a diuretic and they're losing potassium, an ACE inhibitor in combination with it may balance that out, and they will have, normal potassium levels. So some of them are actually beneficial. And then some agents obviously have a beneficial effect on comorbid conditions. Now, real quick, I wanted to discuss this because you will run into this in the hospital, especially if you're working in like an emergency or a cardiac floor. This table is indicated for pediatric hypertensive emergencies, but a lot of the agents are the same in the adult. Agents like labetalol, you'll see labetalol used a lot, which look at the ending, LOL. So what do you think that is? It's a beta blocker. Same thing with esmolol. That's a beta blocker. You can recognize that because it has that OLOL or LOL. So as I mentioned, these are beta blockers, and some of them have a little bit of an effect on other on alpha and beta 1, beta 2. But these are agents that you will see in a hypertensive crisis or hypertensive emergency. This is different than just having high blood pressure. High blood pressure obviously is more of a chronic thing, but when we have a hypertensive emergency or a crisis, patients are at risk for having actual organ damage to their brain, to their kidneys, to their heart. They're so constricted that they can actually have detrimental effects to the organ systems, essentially. So in these cases, we need a quick-acting vasodilator or agent that's going to open them up, essentially. You will see sodium nitroprusside used a ton. It works very fast. There are some side effects with it. I know Dr. Meissen talked about this within the other lectures. So take a look at that. But the main ones that you will see are sodium nitroprusside, and you'll see labetalol used a lot. And like I mentioned, you'll see hydralazine sometimes too. I just wanted to bring those up because that's something that you will see, unfortunately, in the hospital. So consequences of hypertension. Now, this is just general hypertension. Obviously, it can affect heart disease. They're more apt to developing issues with heart failure or angina, or it can precipitate angina, and it can also precipitate myocardial infarctions. It also causes kidney disease and development of stroke. So some basic considerations, essentially, obviously there's benefits of lowering the blood pressure. In terms of patient evaluation, hypertension with treatable causes, you're always going to keep that in the back of your mind. Is there something that's contributing to the development of hypertension with this patient? Or even if it is essential hypertension, what other factors are involved here with elevating their blood pressure, essentially? Looking at other factors that increase cardiovascular risk. Do they smoke? Do they have high lipid levels? And a lot of that too, when we're treating, all those factors are kind of pulled in and thought about when how aggressive we are with management of blood pressures. In terms of diagnostic tests, sometimes obviously we'd get like a baseline EKG to look at for any changes there, and you have something to compare to. Echocardiograms sometimes will be done too, because you could see aortic stenosis, or they could have valvular issues that are going on. It's just good to get, that baseline echocardiogram as well, because that also looks at the ejection fraction of the heart, and essentially that's how well the heart is functioning and pumping out to the body. Because obviously if a patient has long-term hypertension that's untreated, they're obviously at risk for developing heart failure as well. So treatment goals obviously are to reduce the blood pressure and to make or educate your patients on lifestyle factors as well. Therapeutic interventions like that would be addressing their diet, smoking or alcohol use, or even sleep apnea, as I mentioned. In terms of lifestyle modifications, this is very important because really this is how we should be treating hypertension. Not just throwing them on medications and hoping that it takes care of it. Because, unfortunately, a lot of this can be, their blood pressure can be reduced. Sometimes just a 10-pound reduction in weight can, make a patient go from pre-hypertensive to not hypertensive, or having mild hypertension to, being within normal. So it's really important to educate your patients on sodium, basically sodium restriction, a DASH diet, which your book it has a section in there on that too. And a lot of this is obviously related to their eating and their diet, and it's all to reduce the blood pressure. Alcohol restriction, because obviously it's going to bump up their blood pressure, making sure that they're getting exercise, smoking cessation, maintenance of potassium and calcium intake, because those actually have a direct effect on blood pressure levels as well. As I already went through with the pharmacologic therapy, minimizing adverse effects with these patients so that they are adherent to it, understanding why adherence can be difficult to achieve. A lot of it's education. Most patients don't even really realize their blood pressure is high, unfortunately. It's kind of a silent disease. So when they really don't feel it, they don't really feel the need to take something for it. So I always recommend, too, for my patients to take their blood pressures at home. That's another thing, too, and kind of keep a log or a diary with their blood pressure readings. Because a lot of times you'll find that their blood pressure will be elevated in the office, and sometimes it'll be fine at home, or vice versa. You know, they may have some readings that are low and some that are high. And it also gives you a pattern as to when they're running high. Are they running high, towards the end of the day when their medication's wearing off, essentially, or in the morning before they take their medicine, is it high? It just kind of helps you with the treatment plan as well. Minimizing side effects, a lot of this is through education and informing them about the side effects. And then just working on diet and exercise together with the patient as well. Simplifying the regimen, that's very important, and that's where a lot of these agents, where they're combined, like you'll see an ACE with a thiazide diuretic, like you'll see lisinopril HCTZ or another agent combined together. And it's so that they only have to take one pill, but actually there's two agents within it. So just simplifying the regimen for the patient, it promotes adherence essentially. Real quick, because I wanted to discuss this with pregnancy, chronic hypertension. So there's two different things here. A patient can start off having hypertension during pregnancy. They could have it, obviously underlying before they even get pregnant. So it's kind of crucial to talk about patients about what they should and shouldn't be taking when they become pregnant. ACE inhibitors, ARBs, and then the DRIs, they're also contraindicated during pregnancy. So patients should not be on these agents. Most of the other agents can be continued during pregnancy. Now, there's preeclampsia, which you'll cover this when you get into your OB rotations. In eclampsia, this is essentially brought on and started during pregnancy. This is different than hypertension. A lot of these patients are treated with magnesium sulfate or hydralazine. So those are usually the two agents that you'll see with preeclampsia. But for right now, the biggest thing I want you to know is that, ACE inhibitors and ARBs essentially should not be used during pregnancy. Most of the other agents are okay to continue. So they will conclude the lecture on hypertensive therapy. Really, a lot of the stuff with the certain medications are provided in the lectures that Dr. Meissen went through on specific agents, but this is kind of how to look at it. Go through the charts on here, and really those are like the side effects that you need to know. Like those are the important ones that to concentrate on. And I just thought it would give you a clear description as to, what agents use for what and why we, choose certain agents for a patient. If you have any further questions, please let me know. Thank you.